Welcome to Family Health by Mini First Aid. Mini First Aid are the UK's leading family first aid provider, and we are delighted to bring our latest podcast series to you, giving you all the information that you need around family health subjects. Thanks for joining. Welcome to the Family Health Podcast. This podcast is brought to you by Unity Mutual, a trusted partner for your savings and investments and partner that understands your commitment to your child's health and financial future. When you choose Unity Mutual for a junior individual savings account, you secure your child's savings journey and receive a free mini first aid class. But it's not just about caring for their health, it's also about setting them up for a brighter future. Unity Mutual believes in enriching lives beyond pounds and pence, empowering you with both financial stability and life-enhancing opportunities. Let's dive in. Hello, I'm Kate, founder of Mini First Aid. Welcome to our podcast, Family Health by Mini First Aid. I'm absolutely thrilled that you've decided to join us for Series 2 of our podcast, where we continue to bring you top family health advice from our leading experts. I'm very pleased today that our guest is Ed Rothera. He is a consultant paediatric anaesthetist at Leeds Children's Hospital. Ed is passionate about parents understanding more about what happens when a child goes in for an operation so that families are prepared and not so terrified by the experience. Ed, welcome. Thanks for coming.
Thanks very much for having me, Kate. It's a pleasure to be here.
Tell us a little bit about yourself. Tell our listeners a little bit about yourself and your job.
So, as you said, I'm a consultant paediatric anaesthetist at Leeds Children's Hospital. I've been a consultant for about 9 years, but I did all my medical school in Leeds and then my training in and across Yorkshire. So I only look after children, and I look after them for a wide range of sort of medical and surgical specialities, and that's both emergency and elective work. Other than working in Yorkshire, I live in Yorkshire as well with my wife and 3 daughters and our little dog Fig.
Brilliant. Well, welcome and thanks so much. There's so many. I've got mountains of questions, so we will motor through them today. But I think the main point for our podcast today was to make sure that parents listening, whether your child has emergency surgery or elective surgery, is that you have that reassurance and you understand a little bit more those questions that sometimes you want to ask the anaesthetist or not sure about. Tell me first of all then about what a typical day looks like for you when you're in the hospital. Is there a typical day? Is that a thing?
Yeah, I think there is a reasonably typical day, and I think that would probably be more of an elective work day. Right. So that would be probably a day starting around 7:30 in the morning, and you could split the day probably into 2 halves. So we tend to have what's called a morning list and an afternoon list. So the patients are normally asked to arrive for about 7:30 in the morning, so that's when I'd arrive to see them. And I think that's where one of the issues comes with people is they're asked to arrive at 7:30 in the morning, then we come and see them and say, oh, your procedure's actually not going to be till 11 in the morning. They're like, oh, why is that? So that's because we have the nursing staff, the surgeons and the anaesthetists all seeing the patients. We'll see 3 or 4 patients in the morning, do the procedures in the morning list, and then we'll break to come and see them at lunch. So the morning list finishes about sort of 12:30, 1 o'clock, and then a quick break to go and see the afternoon patients. And then that'll normally start about 1:30 till about 6. Sometimes we do all day lists, so if they're particularly big cases, and sometimes it'll run on into the evening. But I'd say that's a fairly standard day. And I think that's why something like this is important, because actually it doesn't give you huge amounts of time to discuss with parents, all of their worries. If you've got lots of anxious parents or lots of questions, it's actually quite a short amount of time.
It is, and I guess because you're doing this every day, but generally people might only ever have, or maybe none, but you might only have, your child may only ever have one operation. So for you, it's a massive deal, isn't it? What goes into the decision about what sort of anaesthetic children have?
So I think we sort of break that down into 2 factors really, patient factors and then the surgical factors. So the patient factors would be, what is specific about your child that means that they need a certain type of anaesthetic, and then the surgical factors as in, what surgery are they having? So we have to provide a certain type of anaesthetic for that. And I'd say it's a team approach in that the surgeons and us will have discussed about what the needs are, but when I say a team approach, I mean with the family as well. So we need to discuss with the family about what their expectations are. There are obviously options within what we provide that families can decide on, although we will sort of guide you relatively heavily in that. But I think one of the most important things is also involving the children in, not necessarily in some of the more intimate decision making, but certainly in the discussions and being, open and honest about with the kids what's going to happen. And I think that tends to make the whole process a little bit smoother.
So just for me to understand,
Yeah.
for an anaesthetic,
Yeah.
it can go into your body via a mask or through an injection in your hand, broadly speaking.
Yeah.
Is that right?
Yeah, I think so. So what most people will know is they can either have the mask or what people call the injection. We try to avoid terms
The word
like,
injection.
Yeah, so there's sort of this, have you ever heard of the nocebo effect? So there's the placebo effect, which is a positive effect from something, and the nocebo effect, which is sort of negative connotations creating a negative outcome. So we try and avoid things like needles, injections, just because nobody really fancies that, especially not a child. But yeah, on the whole, there's the mask, which is where you breathe in a sort of gaseous anaesthetic agent, and there's the injection in the back of the hand, and people sometimes call it the magic milk or the white milk, which is the one of the anaesthetics used to put you off to sleep. They personally, the injection is a better way to go in terms of it adds another layer of safety, because we've got that little drip in the back of the hand. If there are any problems as they go off to sleep, we're ready and prepped to deal with it. A lot of families prefer to have the mask because they think it's less uncomfortable than having the injection in the back of the hand. Now, actually, these days we have really good creams that make the hand really numb. We have fantastic distraction in the anaesthetic room, so we've got iPads and toys and everyone shouting and making a song and dance to try and keep the kids entertained. And actually, a good, what we would call intravenous induction with the injection in the back of the hand is far smoother than a mask induction. They do both require an element of cooperation, and there are some children that just really struggle with that. So there's a sort of third route where we can pre-medicate some children, so that's giving them some medication on the ward before they come down to make them a bit sleepy.
I'm assuming, just listening to this as a mum, that you must also have rather emotional and nervous parents. There's probably people listening going, look, never mind my child and you entertaining them, I'm absolutely petrified. What's the support, or what do you do for the parents, because they've got to leave their children then to go and have this surgical procedure?
So I think anxiety is very common, and it's really understandable. So I think the first thing is don't be worried about being anxious. We get lots of parents going, I'm really sorry if I cry when they go to sleep. That's not a problem at all. What we try and like is for you to try and sort of be brave in front of your kids and maybe do all your crying after they've gone to sleep. I think it's important to establish why somebody is anxious. So often that's because they've had either a bad experience themselves as a child. Mm-hmm. So anaesthetics has changed a lot over the years. Modern techniques are maybe a bit kinder than they used to be, or they've had a bad experience with a previous child. So we just need to try and identify what that issue was. Is this a very different situation? Sometimes I think it's a lack of understanding, and I don't mean that in a bad way. I mean, it's just that they've maybe got half the story, or they've searched up something on the internet and they just, they don't have the context to put it into. Sometimes it's a very valid reason that they're worried. They might have a poorly child who's having a major operation, and all we can do there is really try and reassure them that they're in the best hands, and that people are making decisions in the best interest for their child. I think the important thing is to try and encourage them not to project their anxieties onto their children, because that then makes the going off to sleep a little bit more difficult.
So are parents or the nominated carer, are they with children to when they fall asleep? Is it a myth that actually it's the doctor is the last person they see before they fall asleep?
We're certainly at the Leeds Children's Hospital, and I would say this is a very common practice across the UK, is we have parental presence at all times during the induction of anaesthetic. So for children that are young enough to sit on the lap, I would have them go to sleep on a parent's lap, and then as they go off to sleep, parents give them a big sloppy kiss, and then we take it from there. I tend to have a discussion with the parents beforehand, so I'll explain at the point where we're then going to usher you out, because we do have to concentrate on looking after your child.
Yeah, sure.
And so we need to make sure it's safe. But I'm very keen that that the last person that a child sees as they go off to sleep is always their parents, about to give them a big sloppy kiss.
Is it different then when it's an emergency? So a child is rushed in and they need emergency surgery. What's the differences between that and elective?
So, and I think it slightly depends when you talk about emergency. So some people would say emergency surgery, like having your broken arm fixed, or, appendicitis is emergency surgery because it's not planned. But actually that follows a very similar pathway to elective surgery. You've got plenty of time to discuss the options. There are certainly situations where it's true emergency surgery and true emergency anaesthetics. And actually in those times you will maybe spend less time with your child in the anaesthetic room, or very occasionally the child will be taken and put to sleep in theatre, particularly if they're very small babies, if they're particularly unwell, or if it's a really rapidly evolving situation. And that's really to make sure that the team can focus on looking after your child and not necessarily have to have people looking after you and taking you away at a time when they need to focus on the child. Those situations are rare.
Yeah, okay.
And they will be explained to you before, and the vast majority of the time you get to spend hear your child snoring as they go off to sleep. Or purring, not snoring.
Purring, I love that. Do you have a typical number of children that you see every week, or does it really vary?
So it really varies. So my practice is quite varied. So I do some really big surgeries where we'll maybe do, spend all day operating on one child, and then I do some procedures where there's maybe 4 or 5 children on a list in the morning and 4 or 5 in the afternoon. So, if it's a big week, I might do sort of 4 days of clinical work, so you might only anaesthetise 4 children. The next week it might be 40 children.
Right.
And then if you do what's called acute work, which is the emergency list, which can be anything from fingers trapped indoors to really big major operations, that can be very variable, and that operates for 24 hours a day.
Gosh. What's the most common reason? I know there's parents listening going, I don't want to think about my children having an operation, but what's the most common thing or reason for children needing to have surgery? Is there a common thing?
There is. I think there's really common things. So and again, I would split that into elective.
Okay.
So what's common electively, and then what's common acutely or emergency. So electively, the really common things are minor ENT surgery, dental surgery. There's quite a lot of sort of investigation, so radiology. So lots of things that adults would have awake that children just can't tolerate awake. So things like MRI scans and CT scans where you just need to be able to lie still for half an hour. Kids aren't going to do that in an MRI scanner. So we do a lot of MRI scans asleep. There's also obviously, people don't necessarily want to talk about, but cancer is prevalent in children, and there's a lot of the treatments that we do for children for the cancer that we do when they're asleep, whereas in an adult you would have it awake.
I didn't know that.
So particularly things like some of the chemotherapies, some of the tests and regular blood tests that adults would all have awake, we do it asleep for children, and things like radiotherapy. So they're the sort of common or small things. From an emergency point of view, it tends to be things like general surgery, lots of appendicitis, lots of operations on tummies for sore tummies, lots of orthopaedic procedures, so broken bones, lots of plastic surgery procedures, so fingers trapped indoors. They're the sort of minor or smaller things. Obviously we get, the bigger things, big accidents and very poorly children.
I remember, so one of my children had, I guess, elective and I guess particularly minor surgery, but he had grommets.
Yeah.
And I can still draw on that when you were talking about, parents being with you.
Yeah,
and I got to hold my son as he was put to sleep.
Yeah.
And there was lots of entertainment. I can remember that.
Yeah.
I can remember that. And I can also remember them putting him down and then having held it together, crying down the corridor.
Really common.
But it is that piece of just knowing what's going to happen.
Yeah. And how did you feel about him going to sleep in your arms?
I found it...
Was it explained to you what it would be like?
Yeah. So I think probably the adrenaline meant that I probably didn't listen as much to what was going to happen. So I was still surprised by the process. I think that's really why we wanted to chat to you today, because I think perhaps parents in the moment, in the emotional moment, aren't necessarily listening. But it was years ago as well. So I think things have changed massively in the way
But I think you see sometimes a shock on parents' faces when a child goes, because, you can say to them they're going to go sleep really quickly now, especially if they're having, the injection, and they're going to go floppy like they were when they were newborn. And no matter how many times you say it, the parent's like, oh my gosh, and then they have to, pick up this, very limp body and put it down and give it a kiss and they'll be snoring. Then there's often a sort of hive of activity once that bit's happened and we're sort of going, all right, come out now. And
I do remember him going sort of quite floppy very quickly. And a little cough. He did a little cough.
Really common. With the mask, it's a bit more predictable in that, often they'll not particularly like it at some point, have a little wriggle, but having the injection, it can be really quick and a little bit not shocking, but it can sort of take you a bit back if suddenly you realise they go to sleep really quickly. And then everyone says, you've not got any of that spare, have you, that we can use?
This is for bedtime. But what I should say is that after his operation, if you asked him what had happened to him in the hospital, it was all about his hand. Because he had no idea that he'd had grommets put into his ears. Because it was all about his hand, and then he got this wonderful plaster. So that's what he was showing everybody back at preschool.
I think that's as an anaesthetist and a paediatric anaesthetist, we play a really important role, because actually, despite the fact that the surgeons do fantastic work for the period when they're asleep and have done all that work in the lead up, a lot of people remember, it's the anaesthetic they remember. That's the bit that they're awake for, then go to sleep. They don't remember the surgery at all. And so I think we play a big role in reducing people's anxiety and making it a more enjoyable and pleasant experience.
Yeah, I'm sure. Now, I'm sure from talking about the emergency surgeries that there are also some children having surgery as a result of avoidable accidents. What are some of these avoidable accidents? Are there things that people could listen to now, learn from, and perhaps keep their children a little bit safer? Or put precautions in place?
I think that there definitely are, and I would put those into categories of things that are, easily avoidable and should be avoidable. So, children up to about 3 years old put lots of things in their mouth. And you need to be really careful about what you leave around. So button batteries, people have heard it again and again. We see a lot of swallowed button batteries, and we see a lot of complications from swallowed button batteries. So either don't have button batteries in your house, or keep them locked away. The big gel capsules that people use for laundry detergent that look like big sweets and jelly beans, the actual gel itself can be really quite caustic if it's ingested. I would avoid buying those personally and just use the liquids that just aren't nearly as interesting to children. If you have blinds in your house, avoid having blind cords about. Don't leave your children unsupervised in baths. So I would say 5 years old, 6 years old, up to that age, they need to be supervised if they're in having baths. Always wear a bike helmet. Whether you're on a scooter or a bike, always wear a seat belt. Not lap belts. I don't think many cars made these days with lap belts, but seat belts, even if it's just a short journey. I would say they're the big things that are really easily avoidable. Then you come on to the things that are cause a lot of injuries, but actually, if you're going to start restricting these, you're going to become a real fun sponge like me, which is my poor children.
Can't do. Well, you see it every day in work.
Exactly. I see it at work, so I come home and go, right, that's going. No, you're not having that. That's gone. So we see lots of broken arms and lots of broken elbows, and the big four that do it are trampolines, scooters, monkey bars, and bunk beds. But I'm absolutely not going to sit here and say don't let your kids on trampoline, scooters, monkey bars or bunk beds.
That would ruin my house forever. That would be a game over in my house. That's our furniture and our play equipment. Gosh,
And then the slamming doors as well. We see lots of kids with trapped fingers, so you can get little protectors you put on the edge of doors. But some of these things you just can't. You just can't protect against, really, just being a bit aware of them. So one child on a trampoline at a time, maybe.
Okay.
Avoid that double
Listen
bounce.
to that one, folks. There you go. You've been told it here now. One child at a time on trampolines. There we go. We're going to talk now about families being prepared for surgery. And one of the things we were chatting about prior to coming on the podcast today was all about fasting and people going, when can my kid eat before they have surgery? So what preparation is done for the family, the child and everything before they have an op?
So there should be some communication from the hospital or the trust that you're going into about when your child is having their surgery and what those fasting guidelines are. Unfortunately, what you'll be told is that you're on a morning list or an afternoon list,
right? And
therefore you won't necessarily know if you're first thing in the morning, so 8:30, or you're later in the morning at say 11 o'clock. So what we have to do is tend to give fasting guidelines as if everyone is first thing in the morning. So it used to be what's called the 6-4-2 rule, which is 6 hours for solid foods, cow's milk, anything fizzy and sweets, 4 hours for things like breast milk, and then 2 hours for clear fluids like water and squash. We moved away from that in terms of the clear fluid to allow a much more liberal use of clear fluids in children. And now, certainly in some areas nationally, but certainly at the Leeds Children's Hospital, we allow free clear fluids up until you come down to theatre. So as long as you're not sort of necking a pint of water just as you leave the ward, actually we let kids drink diluted squash or fluid on the wards until they come down. And that actually, it's not like having a bowl of cereal or a bottle of formula milk, but it does make them less anxious. It makes the parents less anxious. It gives the parents something that they can give to their child to try and placate them. So I think that's something we're moving towards.
When you take your child in for an operation, from that moment that you walk through the doors, what's going to happen? So
I think, the first thing is to say that it's going to be very busy. Certainly at this time of year, because you've got everyone coming in for their surgery, but you've also got all the winter pressures within the NHS. And, we see and hear on the news all the time that it's a strained system and, people are working to the best of their capacity. So, try and bear with them. I think it's important not to judge what's happening to other families as the same that's happening to you. So if you're sitting on a ward and something's happened to one family, that's not necessarily the same thing that's going to happen to you, and every child's needs are different, and so we try and do it as a very tailored approach to that. I think we do try and prepare parents for coming into hospital, so there are things that you can do to make you and your child more prepared when you arrive in hospital. Whichever trust that you're coming into should give you some kind of pre-information leaflet, but there's also stuff that you can access out there, like there's the Royal College of Anaesthetists does some literature called Respare, which is just some video infographics for kids to watch about coming into hospital. And there's a really nice app these days called the Little Journey app, which is if your trust is signed up to it, it allows you to sort of see the wards, see the pathway, see coming down into theatre, see some of the people that you're going to meet, so that actually on the first day it's not so intimidating when you come in. I think, like I said, you'll come in early, but you may not be having your surgery till a bit later. Be prepared for that. We normally try and go in age order, so the younger your child is, normally the earlier they get to go. That's not always possible. Is that
because little ones are less patient?
Yeah, absolutely. Yeah, it's difficult to tell a 3-year-old that you can't eat and drink for however many hours, whereas actually a 10-year-old...
You could have a bit more of a rational... You'd hope you could have a bit more of a rational conversation with them.
But then you have to accept that sometimes there's a clinical situation that might mean that 10-year-old has to go before the 3-year-old. It's difficult, and it is difficult to manage parents' expectations, but I think that's why things like this are great, because actually the more informed people are, the less worried they are, or the less sort of angry they get when they come in and realise they're going to have to wait for a little bit.
I'm assuming that parents can't influence the list either, because I think people might feel, or maybe if I ask the right questions, or there is no influence on the list.
No, I think that the order is done on I would say age is priority number 1, and clinical scenario is priority number 2. So no, I think you don't have a lot of influence on the day as to how it can go. And then, so you'll come in, you'll be seen by, lots of people, and they'll ask you all the same questions. You'll sit there going, why am I being asked the same questions? And it's all for safety. It's to double check who you are, what operation your child's having, making sure it's the right arm that they're going to fix. And then, you'll come down to theatre, and we'd always encourage you to walk down to theatre. It keeps it keeps your child warm, keeps the blood flowing, so that rather than coming down on trolleys, and try and make it as sort of personal and as least intimidating as possible. So we don't want it to feel like although it is in a hospital and a big medical procedure, you don't want it to feel like that the whole time. And then, like we talked about, we can have one parent with a child up until the moment they start snoring, and then you can come back into recovery as soon as they're awake, really.
One of the things that, I can't actually remember from when my son had his operation. What do children have to wear to have surgery? Do they wear a hospital gown? So
it slightly depends what you're having done. So with your son, when he had his grommets done, he could just stay in his normal clothes, because he's just having what would be considered, relatively dirty procedure in that it's on the outside of his ear. They'll clean it and they'll keep it sterile, but they're just doing it on the outside of his ear. It takes about 10 minutes. If you're having an operation on your, on your tummy, really you need to come down in a gown. Now we have lots of children that won't get into gowns, and then, we undress them when they're asleep. So again, it's tailored. The one thing I'd say is try not to bring your kids to hospital in onesies. Because they keep your kids warm, but they're just a nightmare to try and get them out of when they're having surgery.
No onesies, folks. You hear that?
No onesies.
Yeah, you hear that
until afterwards.
Yeah, no, you talked about.
Or don't people bring them in beautiful dresses and lovely new pajamas. Bring them in cruddy old pajamas. So you don't mind if they get a bit of surgical clear up. Some of the antiseptics that we use to clean them and things like that.
Okay. You talked a bit about recovery. What happens in recovery? So they come out.
Yeah.
What happens?
So recovery is obviously after the surgery is finished, but while the anaesthetic is still having some effect. So we aim to get parents down to recovery as soon as possible, but we have to make sure the child is safe. So what we don't want to do is get a child into recovery, get the parent in straight away, and then the child have some kind of complication, maybe a minor complication where we need doctors or nurses to interact, and then we've got parents sitting there going, oh gosh, what's happening? Yeah. So we make sure they're safe. Now that often means that they might be awake when you come down, but actually they're not going to remember that period before you get there, because they've probably had quite a lot of medication, quite a lot of pain relief. So although they'll be awake in terms of eyes open, actually if you ask them the next day what's the first bit you remember, they might go, oh, having toast up on the ward. But we do try and get parents down really quickly, and I know a lot of parents will say, oh, I need to be there as they wake up, and we would always try and encourage that and get parents, and you can have more than one parent as well, so parents down as they wake up.
And can they eat quite quickly afterwards then?
So it slightly depends on the surgery that you've had, but the vast majority of the time we would encourage you to eat and drink quite quickly. Now we would say try and curtail how much you eat. Often kids will be absolutely ravenous and then want to eat like a big bowl of cereal or lots of toast, and then they might say themselves quite sick. So we just say little bits at first, build it up. The vast majority of surgery we do is day case stuff, so minor stuff like we talked about, and one of the discriminators for being able to go home is having had something to eat and drink, being pain-free, having gone to the toilet. So yes, we encourage you to eat and drink, particularly for little babies that are breastfed. Sometimes we'll encourage breastfeeding in recovery, so as soon as you come down. Okay. The floodgates can open for food and drink. Yeah.
Is the toast as good as the maternity ward toast?
I do not know what it is about NHS toast. It is cheap bread and cheap butter, but it is.
It's dreamy. It's the stuff of dreams.
It is the stuff of dreams.
And children seem to love it as well.
I know. If you took that same bread and that same butter home and made it home, it would be trash. Yeah. But for some reason, made in a hospital, everybody loves it.
Do parents find it quite emotional when their kids are coming around? Do you see people getting quite upset at that end of the...
Yeah, I mean, there's obviously a huge sense of relief. And, we can sit there until we're blue in the face beforehand and say, you don't need to worry. We've done this lots of times before. There's nothing in your child's history that suggests there'll be any trouble. Your child's going to be absolutely fine. But until your child is back in your arms, you're never going to believe it. And so there's obviously a big sense of relief, when they see their kids back. I think sometimes if they're regulars, so we have kids that have been in, 10, 20, 30, 40 times, sometimes it becomes a bit more sort of, oh, they're here again, great, thanks very much. But a lot of the time there's, definitely
a one-off.
Yeah.
It's a big thing, and like you said, is that if you're managing anxious parents and parents that are quite distressed, it sounds like all the brilliant things are happening to allay everybody's fears. And we will put today in the podcast notes today the resources that Ed has shared around things that you can do with your children in advance to operation. Is there something, Ed, that you would want in particular parents to take away from listening to you chatting today?
So I would say kids are remarkably resilient. Every day I'm surprised by how tough kids are. They will whinge and complain far less than an adult would about the same thing. And I think the one bit I'll take away is try not to project your anxieties about what's happening to your kid onto your kids. Yeah. This says the man that doesn't let his kids onto a trampoline. So maybe I should take some of my own medicine.
There we go. There we are. So a little bit of a self-advice there as well. Ed, it's been an absolute pleasure for you to join us today. Thank you so much. It's been absolutely fascinating. I've learned absolutely loads, and it's really good for parents and carers listening that hopefully you feel so much more comfortable if your child is about to have an operation, or perhaps if you're ever faced with emergency surgery. So thank you. Thank you for coming to join us today. If you've enjoyed today's podcast, please do subscribe to our social channels and the newsletter, which will keep you up to date with the latest episodes. And if you want to watch Ed and I chatting, some people like to see us in person chatting, then you can see us on our YouTube channel. The podcast is also broadcast all across your favourite podcast platforms. And finally, if there are other topics that you would like us to discuss in future on the Family Health Podcast, please do get in touch, because we want to make sure that we're providing the family health information that you need. Thank you so much for listening. Thank you for listening to Family Health by Mini First Aid. I hope you found our podcast really useful and informative. If you want to know more about Mini First Aid classes, courses, qualification courses or first aid supplies, please do visit minifirstaid.co.uk or look us up on all your favourite social platforms at Mini First Aid. As you care for your family's well-being, remember that Unity Mutual believes in enriching lives beyond pounds and pence and is here to support both their health and financial future. Choose Unity Mutual for your junior ISA and you'll not only invest in their dreams but also receive a free mini first aid class. Thanks to Unity Mutual for making it all possible. Until next time, stay informed and financially secure, knowing that your journey with Unity Mutual is about more than just money. It's about nurturing your future and protecting your loved ones every step of the way.